Hello, I'm Dr. Jeff Lynch from McKinney-Dentist.com. This video is going to show the extraction and immediate placement of an implant for tooth number 19. I'm going to show all the intermediate steps, taking you all the way through the final fabrication of the solid zirconia screw-retained crown. As you see here, we use an Optigate to help keep the lips out of the way. Tooth number 19 had endodontically been treated and had periapical lesion on the distal root. I start off using this forceps to just see how solid the tooth is. I move the crown around a little bit. I like to get a little feel for the root stability and if the tooth is mobile. My intention here is not to remove the tooth with the forceps at this point, obviously. I just want to get things moving and feel if I'm going to just pop this crown off or not. Next, I'm going to be reflecting the tissue. I'm going to be using a periotome to gently cut through. Then I'll use a small boozer periosteal elevator to reflect it down to the crest. I will be using a burr to cut the crown off and then section the tooth as well. And I want to see where the crest of the bone is, both on the buccal and the lingual, so I don't go in and damage it. The idea of an atraumatic extraction is to leave the bone intact, and I sure don't want to grind a big old hole or groove in it to begin with. To remove the zirconia crown, I like to start off using a large, coarse occlusal reduction burr. It helps me get through there pretty easily. You got to use a lot of water or else these things will spark. And then I'm going to use a crown remover, also known as a short-handled, flat-headed screwdriver, to just break the crown off. To section the tooth, I'm going to be using a surgical length 1558 crosscut Fisher burr and a large tapered barrel diamond. When you're sectioning the tooth, you've got to have a perception of the angulation of the roots so that you don't cut through a root and create yourself a weakened section that increases your chances of breaking the top of it off. Also, you have to realize you're going to have to go deeper right down through the center of the tooth. So the way I do is I start going deeper there and I feather it up towards the edges. Again, I'm trying to preserve the interceptal bone as best possible. As we go through, we're going to be getting rid of the gutta percha and just carefully feathering it deeper. And then after I do this, I'll go in with the barrel and widen the gap between them, because when I start to luxate these roots, they're both going to go towards the center of the tooth. The distal root's going to go to the mesial, and the mesial root's going to go to the distal. And I need to have room for them to move before it bumps into the other portion of the tooth. So I just, again, carefully feather back and forth, creating space for myself and visualizing where those roots go. I want to be able to look down through my cut and make sure I get down to bleeding bone without taking too much of it away. And also, again, being careful to not go into the lingual or the buccal plate. Now I'm going to use a approximator to see how my mobility is. But initially, I see as I look down in there, there's a portion of the tooth on the lingual that I did not fully section. If I try to luxate these roots with that not separated, I will for sure break off a piece and make my job a lot harder. So I'm going to go back in, back with the crosscut fissure and make sure I completely separate the mesial and the distal root. Now once I've done that, I'm going to come back in with my approximator. These are great instruments. I use them sometimes in a form of an elevator like I am here. They've got some flexibility in the handles which allow you to put pressure on there without breaking the root off. They can come at you from the distal or the mesial. You can also use them sequentially after using a periotome, where you're going to force it down into the PDL to get the tooth to move, get the roots moving a little bit by compressing the bone. But in this case, I'm definitely, you can see me moving it around, getting the tooth to luxate distally. I'm also lifting it. Again, it has a bit of a spring action to it. So my goal here is just to get these roots moving back and forth before I lift them on up out of there. Here I'm going in with a apical retention forceps. These are by Schumacher, also the same people who make my approximators. Then I'm just going to come in with a angled elevator, push that mesial root a little further distally, and get it out of there. Now that we've got the tooth out, we go into degranulating the socket, and I like to use these Strauss degranulating burs to begin with. They are very coarse latch angle burs. I use on the end of an implant handpiece with irrigation, probably around 1000 RPM. I start off here and I can't reach the base, so I put the burr extender on it. Helps me reach all the way down to the bottom. So what we're going to do with this is we're just going to run it around the edge of the bony walls, not using too much force in any direction, but just rubbing it. I like to let them just go in circles. You can see the wall, it's just kind of like we're cleaning it off. This gets out any granulation tissue and any ligament fibers, just getting down to good, clean, healthy, bleeding bone. As I continue to work on the distal root socket, the area where the distal lesion was, we've got a pretty significant undercut area in there, so I'm going to work these burrs down in and around there and make sure that I remove any infection or granulation tissue from that spot. My assistant's also going to go in with the small surgical suction tip. Now I'm going to go in with the angled curette, and these are serrated. We can get down in there and get around the corner and make sure that we don't leave any tissue down in there. We just want to make sure we've got good, healthy, bleeding bone. This is a Lucas curette. It's a very small serrated one, and also allows me to get down into the very apical portion of the socket, again aiming to get the bone completely clean. In immediate placement cases, I almost always start off with a Lindemann drill. It gives me the opportunity to create my starting point. I don't need to worry about taking it completely to depth. I just want to get the bone cut to the point where I can get my first 2.0 twist drill to follow it. Now that I've got my 2.0 twist drill to depth, the next thing I'll do is break out the Versah burs. The Versah burr can cut either in a clockwise cutting rotation or a counterclockwise densifying rotation. So I'm going to start off going clockwise and forward cutting and take that down to our 12 millimeter pre-planned length. When I remove the burr, I see that I do have a loose piece of interceptal bone in here. I'm going to retrieve it and soak it in the L-PRF juice that we're going to eventually use to mix our bone graft in. So go back in there, make sure everything's smooth down to the depth, and at this point I'm going to use this to take a check radiograph. A radiograph looks good. I am right down in the interceptal bone. Now we're going to go counterclockwise, reverse rotation, and start densifying at about 1200 RPM using water. We're going to be pumping in an up and down motion, just condensing the bone. Mostly here we're in interceptal bone, but we're also going beyond where the apical extent of the root tips were, and we're going to be creating a dense apical portion where we're going to be getting some very important initial stability for our implant. Now we're going to go continuing up in size. We're using the VT2535, the VT3545, and finishing off with the VT4555. Those sizes are representative of the apical and more coronal or end of the shaft sizes for these burrs, all according to a really nice graph that a chart you can see on the Versah.com website. At this point, my osteotomy is complete. I've got good bone, I've got good apical bone. I'm going to take out my pre-planned implant, which is a Tapered Plus laser lock. I've got a 5/8 by 12. This is a really nice implant. I've got a good solid internal connection, and I always place an implant initially using a handpiece. It controls the angulation better, and it gives me a good indication of initial torque. So I'm going to then go in with the Ostel and measure my initial stability. This Ostel gives what they call an ISQ number, initial stability quotient, and our goal here is to be up into the 60s or 70s at initial placement. BioHorizons makes these 1 and 2 millimeter high narrow healing screws. I like them. They're basically using a GBR type of a concept where it will be used to support my barriers like a tent screw would. You may have seen some ointment on the end of it. I dip it in Neosporin, place it in there, and then I will begin to build the bone around that. Once the bone is built up, I will cover that with a piece of PRF soaked collar tape and then cover that up with a Cytoplast TXT 200. The bone, I'm using sticky bone, which is a mixture of L-PRF and the blood that we get from that draw. I'm using cortico-cancellous mixed bone here. I'm going to be placing it in small increments. The idea here is to not be super dense. You want to make it dense enough to be to maintain space and give the new osteoblasts a matrix to grow over, but then again not so dense that new blood vessels and the bone cells can't get through it. You're not trying to condense this like an amalgam. You just want a good solid fill. So my assistant brings me over a small scoop at a time, and I go in and condense it around the implant. This bone is sticky. It'll stick to things. It holds together, clumps well, doesn't flow all over the place, as you can see here. Gives me good control. Somewhere along the line here, I'm going to start getting some bleeding. Then my assistant will place a wet 2x2, which I'm going to condense down, absorb some of the extra blood. Gives me an opportunity to see where I'm at. And then we just keep on filling until we bring it right up to the top, which will be about 2 millimeters above the height of the implant. We want to get the very crustal portion covered in bone. And again, this 2 millimeter screw will do two things really. One, it's going to support my barriers, but two, it's going to do what I call a auto second stage, which you're going to see at our 4-week period. What it's going to do, we're going to remove the cytoplast barrier at 2 weeks, or at 4 weeks rather. The suture will come out at 2 weeks, and at 4 weeks the barrier will come out, and in most cases at that point the tissue will be covering everything except the very top of this 2 millimeter screw. Then we can apply some topical if needed, unscrew this and put a standard 3 millimeter wide healing screw in there, and there's our second stage without actually having to do a surgical procedure. So as I continue to fill the socket, I'm going to make sure that the bone is packed all the way up to both the buccal and the lingual crest. And then we're going to contour it so it slopes down. Here I'm condensing it with the back end of my periosteal paddle explorer. I want to feel where I'm at there, kind of create a little bit of a space under the flap around the crest where I will be able to tuck in my barriers that are gonna follow. We'll uncover the top of the screw, and then the bone will be packed nice and dense all the way around it, up to the interproximal crests for the adjacent teeth and the buccal and the lingual. Here's my soaked collotape. I'm going to tuck it under the buccal and lingual conservative flaps. I wouldn't really call this a big flap. It's basically 2 millimeters or so reflected over and off of the crest. You want to take care, if at all possible, to not have to reflect any further, so you don't disrupt the blood supply to the crustal bone. That's what causes the crust to resorb. So we want to be careful and take care of the tissue and the bone. I like to use the collotape under the cytoplast as an additional protective layer. Sometimes the patient will rip out the suture. Sometimes the barrier will come loose. You really can't control all of those types of things. And if your barrier is to come out, if your non-resorbable barrier is to come out early, it's very beneficial to have this underneath there to protect your graft further. It's just a little bit of over-engineering, which is always a smart thing to do. Next, we're going to be using this dense PTFE Cytoplast TXT 200 barrier. It comes in a good size here. First thing we're going to do is a little of what I call dental origami. We're going to go in and trim this. You want this to be about 1 millimeter shy of the adjacent teeth. and it's going to tuck underneath your flaps by a millimeter or two. When we're putting it in the unsutured position, it's going to not go under the flap very far. But then when we get to the point of suturing it, the flap will pull up and over. Notice we're not releasing the flap at all. This is designed to be exposed. We do not want to alter the mucogingival architecture at all, if at all possible. When done, this is going to give us some really nice keratinized tissue right on the crest of the ridge and also in our buccal and lingual margins. So we're going to position it in there. My assistant's going to help. You're going to see it's going to tuck up under there just a little bit. Now I'm going to be using the Cytoplast 3.0 suture. This stuff is very friendly to the tissue. BioHorizons also distributes this. We're going to do a crossover type of a suture. I like to use the bone condenser as a protective measure to keep from hooking into that barrier. We're going to go over and across. Frequently at this time, we're going to dislodge that barrier. First, when I started using this, it got kind of frustrating, but really we want to just get the suture in there. The barrier will stay put. Then we can go back in and tuck it down exactly where we want it. It also helps with time when your assistant knows what you're doing, and she can help hold it to place. Again, I use the scoop end of my bone graft packer as a protective measure. Try not to suture the lip barrier to his face. And here we go, crisscross over. And then we will have ourselves a horizontal mattress type crisscross suture. I like to do this when I've got good keratinized tissue on the buccal and tie it down there. Having the knot off to the side, generally patients report less annoyance from the suture. Again, the sutures are going to stay in for 2 weeks. This suture is soft, it's pretty tissue friendly, but having a suture in there for 10 days or 2 weeks will get annoying no matter what it is. Next, I'm going to tie down each papilla. I'm just going to do a single interrupted suture on these. Another great feature of this Cytoplast suture is the fact that it is slippery. So notice I don't have to tie and pull the first knot tight at all. The first and second knot will slide. You've got to be careful not to pull it too tight because that will pinch off on the tissue. It hurts them and it gives the opportunity for the suture to pull through. But you also don't have to worry about the first knot being tight because you can cinch it down with the second. Once I complete the suturing, I will compress the flap on the buccal lingual and then the barrier on the occlusal surface. My goal is to minimize the thickness of the clot and compress the graft on the crestal surface. When we take a look at the x-ray that follows here, we're going to see that the bone is built all the way up and around our 2mm screw. We've got coverage over the crest of the implant where the laser lock is, so we'll get good attachment there. The patient's going to be instructed to use PerioScience AO ProVantage gel 5 times a day. This is an antioxidant gel that does wonders for healing, reduces inflammation. At 2 weeks, they're going to come back. We're going to remove the suture, give them additional instructions if we can tell they haven't been using the gel. This guy did. At 4 weeks, they're going to come back. We're going to remove the barrier. All this is going to require is a little topical anesthetic to cover it. And then we grab the barrier with a cotton forcep and slip it out. Once the barrier's out, we're going to see what we call osteoid. That's the new keratinized tissue beginning to grow. We may have a few little chunks of bone graft material, but we're also going to see the top of that 2mm screw. So, time for a new one. We're going to clear out any material in the top of that screw. When we remove a screw from a freshly placed implant, it's important that you not just use a slow removal force, but we need to break it free with a quickly, sharply applied force so the screw breaks free from the implant without creating any torque on the implant itself. Once that screw's loose, we can go back in and remove it with finger pressure easily. The key is, again, not to let the screw be engaged to the implant at all. We don't want any rotational forces on a freshly placed implant. So that screw will come out. Then I'm going to place a 3mm tall, wide healing screw and gently tighten it down. Again, once we get to the tightness spot, we don't want to sit there and crank it and potentially generate any rotational forces or movement on that 4-week-old implant. When you look around the screw, you're going to see nice keratinized tissue on the buccal and lingual. That new tissue on the mesial and distal will granulate in and give us nice keratinized tissue. Patient's going to come back at the 3-month time frame. At this point, tissue is completely keratinized in. We've got beautiful tissue all the way around it. Remove the healing screw. We've got beautiful tissue there. We're going to place our scan body for our iTero scanner to make the crown. 3 weeks later, the patient's going to come back and get this beautiful full zirconia screw retained crown made by my friend Hussam at DDS Lab. Great fit, contour, aesthetics, and that's it. If you've got any questions about anything that I talked about or showed in this video, feel free to email me, jsldds@gmail.com. You can look us up, McKinneyDentist.com. We practice in McKinney, Texas, which is about 30 miles north of Dallas. Hope everyone's doing well. Bye-bye.